Good afternoon, everyone. On behalf of TELUS Health, I would like you to welcome you to the 16th Annual TELUS Health Conference, provided virtually this year, given these extraordinary circumstances we're living through. My name is Jason Kennedy, and I'm a Director of Health Business Consulting on the Health Benefit Management team at TELUS Health. Today, I have the honor of being your MC for this webinar. Before we begin, I would like to thank our sponsors and steering committee partners, Canada Life, Equitable Life, La Capitale, Sun Life Financial, and Union Life Insurance for helping make this virtual conference possible. We have an insightful presentation that awaits us, but first things first, I'm excited to inform you that we have over 550 participants on the webinar today. And in order to ensure a quality video connection, we ask that you turn off your camera and your audio. It should be muted already by default. Physical distancing, however, doesn't mean social distancing, and we encourage you to virtually network by using the chat function at the bottom of this window. During the presentation, there will be two ways to ask a question to the presenter, one into the chat at any time during the presentation, directing it to one of the panelists. The second will be near the end of the presentation during the Q&A period. We'll share instructions on this at a later point in time during as we near the end of the presentation. If you happen to experience technical difficulties on WebEx, email us at telushealth@telus.com or send a message to my colleague, Susie Kim, via the chat function, and we'll do our best to address these questions. The video recording of this webinar will be available on the TELUS Health Benefits Hub in a few days, and to be notified, simply subscribe to the mailing list if you aren't already a subscriber. And for those Twitter enthusiasts out there, you'll see on the screen here, we have a hashtag #HealthBenefitsTrends to chime in on the conversation. And of course, at TELUS Health, we're always eager to improve. At the end of this webinar, you'll be invited to fill out a 3-minute survey. Please help us get better by filling out and providing your feedback. As it relates to CE credits, they'll function a little differently this year given the sudden change to the format. The attendee participant list from the webinar will be submitted along with webinar material for CE credits. Please allow us a couple of weeks to get back to you. And without further ado, I'd like to invite Laura Mensch to say a few words. Laura leads the Health Benefit Management business, and our mission is to deliver comprehensive and integrated solutions that facilitate the sharing of information between healthcare professionals, insurers, plan sponsors, and plan members, with the ultimate goal of helping companies better manage rising healthcare costs. Please help me welcome Laura.
Thank you, Jason, and again, welcome everyone. The COVID-19 pandemic has sadly claimed too many lives, disrupted economies, and changed our daily existence as we know it. It has also shown us how strong we can be and how creative, even in these times of isolation. We are a few months into what is being called the new normal, a world of teleworking, physical distancing, and the use of masks in public. As challenging as it is, the current health crisis has been a great opportunity for reflection, and hopefully for many of us, a bit of gazing into the crystal ball. As we gather today at this virtual seminar, it is a natural opportunity to look back at the year that it has been, and perhaps more importantly, to inform our conversations as we look forward to the trends and potential disruptions in the healthcare benefits landscape for this year and the coming decade. I actually looked way back, 100 years ago to be exact, to the Roaring Twenties, which was a defining decade not only for social advancements, but of economic growth and technological change. Ironically, the Roaring Twenties resulted 2 years after one of the most severe pandemics in history, the 1918 flu pandemic. This pandemic peaked the same month as World War I and ended and contributed to the instability around the world in the following decades. But it also inspired a search for causes and cures that contributed to medical innovation and technologies we still use today. Beyond the birth of epidemiology, public health was being formed in many countries. In Canada, the seeds of Medicare were just being planted. Other areas of healthcare also surged. Insulin was discovered, as was penicillin, although we didn't see its use until decades later. Advancements were made in tackling influenza, as well as other deadly diseases such as tuberculosis, measles, and scarlet fever. The decade was so transformational that Forbes magazine renamed it the Soaring 20s. While it may be difficult to picture life beyond COVID-19, I ask, will this decade be like its counterpart 100 years ago? Will we, dare I say, soar again? We certainly hope so. The winds of change are strong, and society is moving quickly, even under physical distancing protocols, especially when it comes to technology and healthcare. The issue is, as I see it, can we be nimble enough to keep up with the way in which plan members are using the healthcare system in the age of COVID-19 and beyond? Can we meet their expectation when it comes to service, affordability, and care? We are working towards that goal, but we certainly don't have all the answers right now. And so today and throughout this webinar series is our chance to begin to look at and define how we build the right foundation to soar into the 2020s. This webinar series considers some very timely and highly relevant healthcare issues and trends. Not surprisingly, one of these is the virtualization of healthcare in Canada. It's a perennial hot topic, and we'll be looking at where we see it going and the potential impact on private insurance. We will look at other issues that are important to the health benefits landscape, such as chronic disease management, trends in medication management, and again, national pharmacare. For this special virtual issue of our conference, we have collaborated with many to bring you these meaningful topics. If you haven't registered for other webinars, please sign up on the registration page before they fill up. So let's get started. We begin this decade with some staggering statistics. 5 million Canadians are still without a primary care physician. Even in the days of pre-pandemic, we've had some of the longest wait times for care in the world. And there's been a mismatch between where physicians are and where Canadians live. The current health crisis has further perpetuated the need for accessible and on-demand health care across our country, and one that strengthens the continuum of care. Recently, provincial governments have been more inclined to leverage virtual care to offer pandemic relief, and employers have opted to offer virtual care to help employees maintain their physical and mental health during this challenging time. At TELUS Health, we are proud of our role as the system connector with the TELUS Health Exchange. The THX is a standards-based platform that enables members of the healthcare ecosystem, such as physicians and pharmacists, to communicate electronically across primary care settings to ultimately help improve care delivery to the patient. It is expected that over the next 3 to 5 years, there will be a bigger push to create this data continuum from the acute care system to community care, back to the consumer, and then ultimately to the payer. That brings us to our second issue, chronic disease. We see parallels here as the innovation in healthcare through digital again will help manage chronic disease among plan members. We have Brendan Byrne, one of our speakers in a few weeks' time, bringing it one step forward, sharing his latest findings around deprescribing chronic disease patients. I look forward to our discussion around this topic. Now, our last trend and issue focuses on drugs, the National Pharmacare Program. While the topic may not be a priority, it does remain on the radar. The discussions are evolving amid the global pandemic. It will be important for us to understand how COVID-19 could alter the rhetoric and where this might ultimately be headed. So here we are with some profound issues as we head into this new decade. This is just a quick overview of some of the trends and issues we're facing now at this important juncture in our time. I started off my remarks reflecting on a defining decade from the past and looking to opportunities now posed by this decade. Just as those who lived through the Roaring 20s, who were not complacent, nor should we be. Through connectivity and innovation, we're building a better healthcare system, one that is not just reactive but proactive, and one that is relevant to all Canadians as it addresses issues of fairness, access to care, and affordability so that we can continue to improve outcomes. Please enjoy this webinar series. Be bold, share your insights and ideas. I look forward to seeing you in person next year. And now let's get started. Back to you, Jason.
Thank you, Laura. I'd like to now introduce my colleague and today's speaker, Sean O'Brien. Sean is a principal and leader of the TELUS Health Analytics Group. He oversees both product and development teams while leveraging TELUS Health Business Intelligence and Data Warehouse platform. Sean has nearly 25 years of experience in employee benefits consulting and group insurance. One of Sean's main roles is to partner with carriers to develop analytics that help employers better manage their plans by identifying key cost drivers, trends, and benefits optimization opportunities. Over to you, Sean.
Thanks, Jason. That made me sound almost important. Happy to be back here again, although in a virtual capacity this year, but certainly looking forward to present our annual trends and benchmarks. So I am under a bit of censorship, given some of the jokes I've tried with the past. So I promise no sheep jokes this year, but yeah, maybe I'll throw in a consultant joke, given I came from years in the field from that field. So it reminds me of a story. There was a posting on LinkedIn that said, CEO in need of one-armed benefits consultant with a life license and 5 years experience. So the successful candidate that got the job asked the CEO, I understand most of the qualifications you required, but why one-armed? CEO answered, I've had many benefits consultants in the past, and I'm tired of hearing them caveat their advice with, on the other hand. Okay, so don't take yourself off mute. I don't want to be disrupted with all the laughter that I'm sure is going on around the country. So with that, I will go to what we're going to go through today over the next 45 minutes or so. So we're going to review our 2019 data compared to prior years where appropriate. We'll touch on our key results like we do every year. We'll go into utilization by drug type, specialty drug analysis, followed by our book of business rankings, and we will end off reviewing time on trends we're seeing in plan design features. So let's get started. Every year we show this to level set some of the terms we're going to be talking about. Our industry is terrible for using different terms interchangeably. So insured, certificate, cardholder, claimant, plan member, you might hear them used in different ways, but sometimes trying to say the same thing. So for purposes of this session, insured will be the total number of distinct individuals covered during the period, regardless if they made a claim, regardless if they were the employee, spouse, or the dependent. But when we look at a certificate, that really counts the employees and all their linked dependents under one. We will also look at eligible costs for the most part, because that way we neutralize any significant plan design differences from one plan to the next. If you look at the adjudicated amount, obviously, you're taking into consideration co-insurance, deductible, and things like that. And just to caution, if you try to compare some of these results to a specific group, they could vary significantly, right, from an individual group that you manage or administer. So things like the coverage level of the plan, demographic composition, coordination with provincial programs, even industry can certainly have an impact when you're looking at plan specific, but that does get fairly neutralized when we look across our entire book of business. The other caution is comparing our trend to insurer trend. I mean, we're talking about two different things. Our analysis will always reflect lower trend than is used in renewals. Trend used in renewals is forward-looking to provide a projection of potential costs over the next 12 months. Our data, and when we talk about trend, is actually retrospective, so it's looking at year-over-year change from 2018 to 2019. The renewal trend also takes into account experience of the group, demographic composition, manual rate of the insurers, and also that trend will include, it's based on all medical, so it includes outside of drugs, so medical claims. So just keep that in mind. Some of the drug types we will talk about, a single source brand, so a drug which is under patent protection still. There is no generic equivalent at this time. Multi-source brand, where there is one or more generic that exists. So an example there would be a drug like Crestor, where the brand is the multi-source brand, but there is rosuvastatin, so there are generics available. And then generics are just a lower cost copy of original brand with the same chemical strength, form, and route of administration, so they're bioequivalent. But also note, we are going to be talking about biosimilar drugs today, which are not the same as generic or brand. So we're also going to be focusing on insureds under age 65 like we do for other years. But again, we have to put the usual disclaimer about OHIP Plus and how it applies. So again, as of April 1st, 2019, OHIP Plus repealed the legislation again. So now we're going to have to do adjustments where we look at, to be fair, to make comparisons, we're going to be looking at, for the most part, the 25 to 64 age group. So our book of business has been increasing outside of Ontario at a greater rate than within Ontario. So outside of Ontario, we've gone up 4.81% of the number of certificates, but within Ontario, it's only 1.5%. Nationally, that translates into a 3.4% growth in certificates. So when we do look at our total insured, we cover nearly 13 million Canadians with over 150 million transactions processed every year. So now let's try some interaction just to shake things up a little bit. So we're going to try a poll. You'll see up there, which region do you think has the highest average eligible cost per claim? Is it the West? Is it Ontario? Is it Quebec? Or is it Atlantic Canada? You'll have a few seconds. So essentially, you're going to check the box and hit submit. Okay, so here's the result. Overwhelming no answer, but let's ignore that. Beyond that, 74 said Ontario, 71 said Quebec of the participants, 40 Atlantic Canada, and 14 in the West. So the answer is Ontario, very close to the cost per claim in Atlantic Canada, 85.72 versus 85.56. Quebec typically does typically have higher cost per claims because of the dispensing in the 30-day supply, even for maintenance medications than 90-day supply. But we look at this on a monthly average cost per claim basis just to neutralize things like that. So here's our key results. And to remove the comparative effects that OHIP Plus has had on Ontario, we are going to show again this year comparisons between the 25 and 64 age group. So Canada's eligible monthly cost per insured was $54.01. The West is the lowest at $40.85, and again, that's mostly because of pharmacare coverage. And then we see when we compare Ontario and Quebec, average eligible cost per claim is higher in Ontario versus Quebec. Ontario, again, Quebec having typically lower cost per claim because of dispensing 30-day supply, so lower quantities per claim. But then when we look at the utilization rates, obviously much higher in Quebec than Ontario as a comparator. Again, because those that are on 90-day chronic medication are filling 30 days at a time, so more trips to the pharmacy. And then if we look at generic fill rates, Atlantic Canada, once again, had the highest, actually hitting 70% of all claims for the first time. So 7 out of 10 claims dispensed in Atlantic Canada are for a generic product. However, it's not really reflected in their cost per claim because, as you're going to see later, Atlantic Canada continued to have the highest percentage of specialty drug consumption. So we will unpack these numbers as we get into the remaining slides. So this is 0 to 64, just to show what actually happened. Again, like I said, we will look at 25 to 64 age band for meaningful comparisons. When I look at this graph, I mean, I can't help but see it as Ontario given the middle finger because of the increase in cost over last year once the repeal of OHIP Plus happened in April 2019. So obviously when that happened, even though it wasn't a full year, it dramatically increased costs per insured in Ontario because now only if the insured is under 25 or if the individual is under 25 in Ontario and doesn't have private coverage, does the OHIP pick it up. So given the significant volume of Ontario represents as a portion of Canada, the impact of OHIP Plus was also felt on a national basis. You see national went up 7.6%. You also see the average age per employee below hasn't really changed, so that's not really a material impact or impact on the claims dollars. So here we're going to start looking at just that 25 to 64 age cohort. See the cost per claim has increased across all regions, netting out at 3.3%. Atlantic Canada, again, the highest at 5%. And again, I'll show in some later slides. A lot of that's driven by, even though they have the highest generic substitution rate, they also have the highest specialty drug utilization and cost percentage. So overall, on a national level, we saw a 1.7% increase in utilization, but it did vary by region. Again, if you look at Atlantic Canada, they actually have a reduction in utilization compared to 2018. So here's what happens when you combine the utilization and the cost per claim components together. The gray numbers at the top I've left there because those were if we included 0 to 64, like we showed on an earlier slide. But if we remove the under 25 age category, Ontario grew at 5.4%, so much lower than the 10.2% we showed before when we remove the impact of OHIP Plus. So now time for another poll. Which type of drug had the highest change in eligible monthly cost per insured, also known as drug trend? Was it specialty drugs? Was it traditional drugs? Or both had the same? I'll give you a few seconds there. Okay, results. Okay, so those that did answer overwhelmingly think it's specialty drugs. Are they right? Yes, of course you're right. So we saw on the prior slide that our overall trend across Canada was 5.1%. But if you look at the growth in specialty drug costs, it far eclipses the growth in traditional drugs. So at 10.1%. When you pull those drugs out, traditional drug spend has only gone up 2.9% year over year. Now we'll further unpack the components of trend. You see that overall, it is a change in the cost per claim, which would be both inflationary increases and changes in drug mix. That seems to be contributing the most if you look at, I'm going to try my laser here. The overall was 5.1, but that was a component of a function of a 3.3% average cost per claim and a 1.7% increase in utilization. But if you look at specialty drug utilization, its increase is really coming from utilization and not necessarily like it's a much lower effect by the average cost per claim has only gone up 2.1, but it's gone up 7.8% on utilization. So we are seeing more specialty drugs coming to market. They're now treating previously untreated or undertreated diseases. So more opportunity to treat disease with these drugs. So we will see increased utilization of these breakthrough products in the future as well. From an age perspective, as expected, cost per insured increase as we age. I know, shocking, right? So younger people typically are claiming more acute therapies, things like antibiotics, which are very, low cost. We are seeing some more mental health related claims in this age cohort, stigmas being removed. So, but those drugs are quite low cost as well, as most of them are genericized. But as we age, certainly start seeing chronic conditions become more prevalent. It's not uncommon to see someone in their 50s and 60s on several medications to treat a variety of conditions that are age-related. So, for example, type 2 diabetes patients would be on a diabetic drug, but often also treating other comorbid conditions such as hypertension, elevated cholesterol, could be mental health issues, and even pain management. So, very, very drug-intensive different therapies are driving costs in the higher age bands. So if we look at age more closely here and bring back in the number under 25 age cohort, we see that we had the highest cost increase over last year. And again, given private plans once again became primary payer for that age group in 2019. So not surprising that we see the biggest cost variation year over year from that age cohort. Aside from that, they're relatively moderate changes year over year. The oldest age band, so we're looking at 60 to 64, had the lowest cost per trend, or lowest trend, so change in year over year cost. But if you recall the prior slide, they're definitely the most costliest on a cost per claimant basis. So even though they're going up by 3.7%, the basis, the starting point is quite high to begin with. Okay, we're going to go into some drug type utilization slides, look at some generic versus brand, specialty versus traditional, biosimilar. So as you recall from the key results slide, our generic fill rate for 2019 across all of Canada was 63%. Atlantic Canada led the way with the highest generic utilization, hitting that 70% on the top you see there. Ontario had the lowest with just 6 out of 10 claims being filled for a generic. Overall, as a nation, we're still far below generic penetration rates of the United States. So they are often in the mid-80s, 80% ranges. But again, the way they structure their tiers, their formularies often promote preferred drug product utilization. So that's how they're able to get much higher generic. So if I look at multi-source, so again, these are drugs dispensed, a brand drug dispensed that did have a generic interchangeable equivalent that could have been dispensed in its place. This is now, we're now hitting, 7% on average. Quebec was the highest at 8%, but Quebec also did increase their generic utilization by 1% if you see the prior slide. So there does seem to be a bit of a reduction in single source brand utilization. So not cost, but utilization. So keep in mind these stats are based on the drug dispensed. So those plans that do have the more rigorous mandatory generic substitution plan design, even though the multi-source brand was dispensed, those plans would have only been paying up to the reference generic price. So utilization from a number of claims perspective across Canada each year, we do see a very slow increase in utilization for generics and corresponding reduction in brand drug utilization. So we're now at 63% generic fill rate in 2019. That was 58% 5 years ago. So we have seen more plans implementing mandatory generic strategies, particularly given some of the provincial pricing reductions. Now, if we look at a cost perspective, it's pretty much the inverse. So single source brand drugs continue to dominate the percentage of overall eligible amount paid, now reaching 70% of total plan costs. So again, this is largely driven by cost for specialty medications. We're also seeing new specialty medications that will reach a broader patient populations for more chronic diseases. So that's going to continue to drive this category upward, we believe. However, there are proposed PMPRB changes that we all know about that if they are enacted, they're says potential to put a downward pressure on patented brand drug costs. So this could look different when we see that. Generics, though, although very highly utilized, only a quarter of the total eligible costs coming from generics. So. Okay, we're going to step in to talk a bit about specialty drugs and biosimilars on the market now. But just to level set again, there's no standard definition of what a specialty drug is. Most PBMs and insurers would consider any drug with an annual treatment cost over $10,000 a year to be a specialty drug. So that does include biologics. It also can include small molecule drugs, so they're not biologics, but they're considered specialty just because of their cost. They generally require special handling and administration, and typically will treat more rare and complex diseases. Again, while high cost, these breakthrough drugs are changing the way we treat serious conditions. So technology has come a long way now with more targeted drug therapy, such as immunotherapy, but innovation and advancements in medicine often come at a cost. So with that, let's start another poll to see how smart you are. I promise this might be the last one. Okay, so as a percentage of total eligible amount paid under the TELUS book of business, specialty drugs represent A, 27%, B, 30%, C, 32%, or D, 39%. Okay, the results are in. Okay, so the majority that answered said C, 32%. And that majority is wrong. It is going up every year, but even a 1% jump like you're seeing here, when we're talking about coming from 1% of claimants, 1.1% of claimants, is significant. We hadn't seen a jump like going up 2 or 3%, and since back when it was the hepatitis C situation, when those newer cure drugs came to market and wasn't really anticipated, or I guess wasn't known how many people were warehousing waiting for them to come out. So it's 30% this year, but again, the number of claimants driving that is still 1.1%. So same number of people using it, but using specialty drugs, but now hitting 30% of overall plan costs. Quite a big difference when you think of where we were in 2008. Still around 1%, but 11% of total cost. So I said this earlier about Atlantic Canada having the highest cost per claim. It's really driven by the specialty drug costs. There are higher prevalence of rare diseases, genetic diseases in that region. If you look back to 2008, it was only 12% of total cost, so it was fairly in line with the other regions. Now it's gone up over 3 times in the 10-year period. But you look at the Western provinces, lower specialty drug costs, much of that to do with provincial pharmacare programs. So they've only gone up, barely just over twice since 2008. Okay, I'm going to look at, again, that 2008 to 2019 period. Monthly cost per certificate for all drugs is now $94. This has increased on average 1.9% per year over that 11-year period that we're showing here. When we layer on non-specialty drugs, they're actually showing a negative growth rate over that same 11-year period. So they're averaging a reduction of 0.6% each year. Now with a monthly cost certificate of $66, but it was $70 if you look back at 2008. And I think much of this can be attributed to generic pricing legislation over those years as well. So there was some reductions, legislative pricing reductions in generics that help lower the total non-specialty drug costs. when we bring in specialty drugs, you see that the cost of these drugs and the slope of the curve growing at a much faster rate than traditional drugs. And they're increasing on average nearly 13% each year over the past 11-year period. If we project forward with the same historical growth trends of each of these drug types, specialty drug monthly cost per certificate could be $55 in as early as 2025. So that may not seem like a lot, but this is the average monthly cost of all certificates, right? Not just those that claim. So only about 1% of total plan claimants are contributing to this large jump in the cost per certificate per month. And when we layer on the overall of all drugs combined, total monthly cost per certificate in 2025 would be $119. So that's an increase of about 26% over the $94 that it sits at in 2019. So, I mean, the message is this sustainable? This will create a whole new set of challenges in controlling costs moving forward. So these are the top 7 drug categories, as we will show in our drug category rankings near the end with respect to eligible costs. But what we wanted to do was see how much is specialty drugs contributing to that versus traditional. So you look at the RA category, it's almost 100% made up of specialty drugs. So, you know, biologic drugs, very little else. There are, I mean, there are DMARDs that aren't specialty drugs that would make up that other 1%. But if you look at diabetes, it's totally different. So it's the second highest cost, but there really isn't any true specialty drugs because we're defining that as drugs that have over $10,000 a year price tag. But there has been an introduction of newer, more costlier drug therapy classes such as the incretin mimetics, the DPP-4 inhibitors, SGLT2 inhibitors. So they're really driving the cost in this category. They're much more effective, but again, costlier. So we're seeing under our book of business about 2/3 of total diabetes drug costs coming from these newer classes of drugs. That combined with more widespread utilization as more and more people are diagnosed with type 2 diabetes. So it's cost and utilization really in this category. Cancer class, we're also seeing higher concentration of specialty drug costs given the new advances in this area. And we know in the pipeline report that we'd sent out, there are certainly some specialty drugs to treat cancers coming down the pipeline. To break out the traditional versus specialty split by region, we saw earlier 10.1% across Canada. But again, you'll see in Atlantic Canada, it's 12.7% year-over-year growth rate for specialty drugs, where in fact they're all non-specialty drugs remained really flat year-over-year. This year, we want to start looking at some adherence rates across key chronic conditions. We calculate adherence by using the medication possession ratio, so MPR. So what it does is we determine that first you look at a drug type for a chronic condition. You look at the time between fills on that medication, and you basically compare it to the day's supply, and you get a ratio over that time period. So we consider anyone with an MPR of less than 0.8 to be non-adherent. So what that would mean, for example, if a person had a prescription dispensed for a 90-day supply, but they never filled the next prescription until after 115 days had lapsed, they would have an adherence rate of 0.78. So we would consider that non-adherence. And we average that across the time period. So it's very interesting to see that some of these products or some of these conditions, taking the drugs on time and as prescribed is critical to managing these disease. When I think about depression, often people, you start to feel better, so you may skip dosages here and there, and that may string out your next prescription. So there's reason for it. Asthma's interesting because it might be a little misleading. I know a lot of asthma is seasonal, so you may have filled an inhaler in the spring when you use it a lot, and then you might not go back to get another inhaler until, you know, the end of the fall or whenever when your asthma has changed. So, but just to show you, definitely across the board, we're seeing fairly high adherence rates. The next few slides are going to focus on biosimilar adoption. So we're focusing on BC just because that province has implemented the initiative to switch patients, that any patient on the originator biologics, certain biologics only, and for certain indications, they're to switch to their biosimilar versions of that. So although this initiative applies to the public sector, we are seeing increased adoption based on, this is all based on new patient starts of the biosimilar. So Basaglar is increasing, and with a reduction in Lantus, which is the originator. So it seems that the public initiative is somewhat influencing physician prescribing habits potentially, because the public initiative is not directly tied to private plans, but we are seeing reductions in the innovator biologic and an uptick in the biosimilars. Similarly, with Inflectra, Remicade, and Renflexis. So Remicade is the innovator, very flat line across the time horizon, but we are seeing Inflectra increasing, and then also Renflexis was not on the market as long, but it's increasing as well as far as patient new starts go. Drug shortages. We observed some drug shortages in 2019. So this is just an example of ranitidine, which would be brand name Zantac, recalled by various manufacturers given there was an impurity found. So you can see how it really dropped off in September. And then we did see a bit of an uptick in utilization of a similar product, famotidine. So just to show when one goes down, there's potential that people substitute for another one. So shortages will have an impact. There has been worry that COVID-19, that there could be drug shortages as people rushed out to stockpile drugs. But we know there were pharmacies that implemented it like a 30-day limit, even on chronic medications, to help guard against that. So there are, from generic drug perspective, we've seen across our book of business in Ontario anyways, about 8% of drugs that have a generic equivalent have a shortage at this time. Okay, I'm going to jump into therapy category rankings. Not much has changed year over year across these categories. In fact, the top 6 haven't changed at all. And then when you look at 7 to 9, they flip-flopped a little bit, and the 10th was the same. So still interesting, though, of the 10, 5 of these you could consider modifiable risks, so lifestyle-based. Diabetes, if it's type 2, obviously it's not all type 2, but if it is, there's ways to manage that. Asthma, if it's COPD, it could be things like smoking that can contribute to that, so there's lifestyle habits that could play a role in that. Depression, certain forms of cancer, and blood pressure for sure. Now our top 10 products, not a lot of shift year over year here as well. We look at trade name. So trade name actually takes the brand name and all its generic equivalents to roll up, right? So Crestor, just the brand Crestor would never make the top 10, but because there's so many generics, then rosuvastatin, that's why you would see it there. Insulin also includes insulin glargine, so that category is largely driven by drugs like Lantus, those newer form of drugs I talked about. What really jumps out here is the year-over-year change of with Freestyle Libre. So it's gone from 40 to number 7. So Libre uses sensors to monitor blood glucose levels. Very convenient. You have your levels monitored automatically and electronically without the need for lancets, test strips. So I think that's driving adoption of this product, and hopefully that type of it will improve compliance, and hopefully we'll see better outcomes. Okay, I'm going to finish off with some plan design slides. So generic utilization, based on our book of business data across Canada, based on the number of insureds under plans that have some form of generic substitution in effect, we see 87% in 2019. So just back in 2015, it was 80% if you look at that. Now we're up to 87%. So the difference between these, when we say regular generic substitution, it's generic substitution applies if there's an interchangeable generic drug, but the physician could write, dispensed as written or do not substitute, and the plan will then pay up to the brand price. The more rigorous mandatory generic substitution, regardless if the physician writes dispensed as written or do not sub, it pays up to the generic price only. You can still get the brand, but it pays up the generic price only. There is an override mechanism that can be done, but it's not left in the hands of the physician. You have to submit a form. So we're seeing more and more plans move to that, and we're seeing a jump from 53% to 56% of that more rigorous mandatory generic, and a drop of the other form, the more simple generic. So we saw 87% of insureds are covered by a plan with either form of the generic substitution I talked about. But when we look at the number of groups that represents in our book of business, it's 94%. Only 6% of all groups under our book have no generic substitution of any kind. And of note, 80% have the more tightly managed mandatory. So although only 6% of groups have no generic sub, that represents 13% of total insured. As these groups tend to be larger unionized groups, right? So it's a little bit harder to, often you have to bargain them in through the collective bargaining agreement if you're making a change to add in generic subs. So. Not much is changing in the coinsurance when we compare 2019 to 2015. We do see a slight decrease in the certificates that were covered under a plan which basically was 100% reimbursement. So it's gone down to 31%. And that shift seems to have moved more to that 80% because it's gone from 43% to 46%. So we do see more and more plans look to contain costs by sharing plan costs with their members. Having the member pay a portion also helps them see the value the plan sponsor is paying on their behalf. So giving them some skin in the game makes them become better consumers. If there's if one drug's covered at a higher reimbursement than another, then they have that choice. Look at annual maximums. Still not a lot of plans have an annual maximum. About 20% of certificates under a book are covered under a plan that has an annual maximum. But we have seen an increase, certainly over the years, particularly in smaller plans where if you have one or two claimants under a smaller plan with a catastrophic illness, it can be very, very significant. So some of the strategies have been for those smaller plans that we're going to offer, we want to offer a plan, but we can't absorb a cost like that. So they may put a lower annual maximum. Some plans had gone in and applied a much higher annual maximum simply because maybe they felt they could absorb costs under a certain level, but if it's over $200,000, they wanted to be protected. Deductibles, not a lot of movement in the 4-year period. Only 23% have any form of deductible. Most of these are from much older contracts, the 25 single, 50 family, or 50 100. They don't do a lot really to provide a meaningful impact on containing costs or sharing costs. So normally the first claim of the year you would satisfy that deductible. So I think we have seen more plans forego the deductible in favor of increasing coinsurance or applying coinsurance. Because when you have a percentage-based coinsurance, at least, it moves with inflation. So if the drug costs are getting higher, you're paying a proportionate out-of-pocket amount. And again, I think that does make the member feel the value that the plan sponsor is providing for them. If I look at per claim deductibles, not a lot of these, but the most common would be either $5 or $2. Dispensing fee caps, distribution has really remained consistent over that from 2015. So there are still about 70% of certificates that are covered under a plan without any form of dispensing fee cap at all. Dispensing fee caps are a good way to incentivize members to shop around to save out-of-pocket costs, or they just pay out-of-pocket if the convenience of going to a higher cost pharmacy is what is okay with them, and they'll pay a little bit more, but it is a good protection mechanism. And if we look at formulary type, most are certificates under a book of business are covered under an open formulary. So it typically means a drug gets approved by Health Canada, it's prescription requiring, it has a DIN, then it gets added. But keep in mind, open formularies don't mean everything's covered. So often you'll have lifestyle class exclusions. It would still be considered an open formulary, but you've excluded a class of drugs. Also, most open formularies will still have a prior authorization for certain high-cost drugs. So even though the DIN is on the open formulary, it has to go through that other administrative layer to make sure it's the most cost-effective first-line therapy to be tried. So we're seeing a very slow progression towards managed formularies, much lower than what we would see in the U.S., but it is increasing. A few plans follow the provincial mimic, and those plans are quite restrictive and will limit access to certain medications. So speaking of prior authorization, we're actually seeing fewer certificates covered under plans with PA. And when I think back at 2015, there were a lot of plans that had prior authorization that was geared towards more lower cost drugs like the PPIs, even drugs like Wellbutrin because it could be off-label for Zyban. But when I think now, more and more plans are covered under prior authorization that's really looking at the higher cost drugs and making sure that the patient's getting the right drug at the right time to balance that plan sustainability. So just to end off, monthly eligible amount per insured saw a 5.1% increase over last year. That was based slightly more on the change in average cost per claim, as we saw, rather than increased utilization. Plans with members concentrated in Ontario would have seen an increase in costs year over year given the repeal of OHIP Plus in April of 2019. Specialty drug costs continue to rise, trending 10.1% in monthly cost per insured year over year. So that's something to keep watching. Adherence could be improved across several chronic conditions categories, which could have a positive impact on treatment outcomes and maybe lower the cost curve going forward. And we saw a slow progression in plan design features to contain costs. I do believe we'll start to see more innovative strategies like product listing agreements, biosimilar strategies, high cost claimant and chronic disease management. All of these start to emerge as plans try to manage costs moving forward. So with that, we'll go to questions.
Thank you, Sean, for the comprehensive and insightful presentation. Ladies and gentlemen, at this time, we're going to open it up for Q&A. Just being conscious of time, we're likely going to go 5 to 10 minutes over, so if you would like to stay, we'd love to have you. There are some questions that came in the chat during the presentation, but if you haven't already done so and wish to ask a question, please follow the directions on the screen, and we'll do our best to cover them all in that little overage time here. So while we wait for Bessie to queue up any questions, Sean, I did receive a couple through the chat here. One came in around slide 31, 32, and it was around your specialty slide. And do these paid amounts include product listing agreements?
They are eligible amounts. So no, they would not be net of any discounts that our carriers would have for product listing agreements.
Okay, thank you. And the next question was closer to slide 46, where you did the breakdown of plan design. Where do multi-tier formularies plan designs fall?
They would be
How
managed.
do you put that under the managed
consider
category?
them under managed, right? So you may have an open formulary as tier 1, or you may have a more of a managed formulary as tier 1, and then you open up all other drugs under tier 2. So example being the national formulary and the SA formulary is tier 2. So we would consider that managed formularies if they're used in combination to create a formulary that is different than their base formulary.
Okay, thank you, Sean. I'm just going to pause here. Bessie, do we have any questions in the queue?
We don't have any questions at the moment.
Thank you. So another question that had come in, how do you expect the adoption of biosimilar drugs to impact the cost trend?
Well, and that's a good point. We did show a 10.1% trend for specialty drugs. So the more biosimilars that come to market and their increased adoption rates, as we saw on some of the other slides, should start to temper that cost trend simply because the biosimilars are being set at a lower percentage of the innovator biologic. So yeah, it would have a positive impact on trend.
Okay, just got a couple through the chat here. What changes do you foresee with drug use and the impact of the pandemic?
Well, definitely, and I made a few comments, and given this is a 2019 retrospective, but I gave some comments about, what we've been tracking and what we've been seeing since, mid-March. We definitely saw reductions in prescriptions, certainly around acute drug categories. I mean, many people weren't going to visit the doctor because of common ailments. That will start to increase with more virtual care visits. So we did see a spike in end of March. Certainly was a jump in people maybe stockpiling who are concerned with shortages. And I rather than wait till, have the full 2020 year and show this next year, I mean, obviously this will be part of the narrative next year, but I think we may be looking at doing a special webinar just on what we've been seeing over the last, because we've been tracking very closely and monitoring the last since beginning of March. So we might be able to share some more with you.
Yeah, thanks, Sean. Lots of commentary on that. So we'll definitely get back to the audience on that one. Maybe a bit of a clarification question from earlier. There was around your age bands. Any sense of why the age band of 25 to 29 went up by 11.6%?
Yeah, and a lot of that did seem to be more around mental health usage. So we did see a higher concentration in that category in those age bands, and we've seen it across the younger age bands in general. And as I said, I do really believe more so than ever the stigma is being removed. Just look at all the different campaigns that are out there and people sharing and across social media. It's no longer something to be embarrassed about. So we do see, I think, more people, even younger people tend to think they're invincible and don't need help, but I think that is changing for sure. So that's definitely a contributing factor to the growth rate in that 25 to 29.
Okay, next question. Comes with a compliment, but I'm going to save that. That's okay, Sean. You don't need to hear it. Is there any data on PLAs, specifically what percentage of high-cost or specialty drugs might have a PLA in place? We don't have that data. Most of those PLAs are confidential, and many of them are not. They're not TELUS administered PLAs either. They're the functionality comes from us, but the negotiation and the terms of those are restricted to our carrier partners. Thank you.
But I mean, I suspect there will be an increase. I just don't know of what drugs and how much.
Thank you. Checking back with Bessie here, just to make sure we're not ignoring anyone on the lines.
We don't have any questions.
Okay, the chat is reasonably active at the moment, so that's just fine. Okay, let me just make sure. As for drug trend projections from now to 2025, how is the drug life cycle incorporated into these numbers? Yeah,
it's not, and I think I said we just looked at a simple linear trend. If everything remains the same and specialty goes up by the same percentage, which really it's unrealistic, but it's directional to show that it's going up. But there's going to be offsettings, right? There's going to be biosimilar introduction, but there will be new biologics come to market. There are some key brand drugs. If you look at our pipeline, a newsletter that went out or that's on the Benefits Hub, you'll see that there are some generic entrants coming, so that'll have some downward pressure on. So long and short of it, it wasn't an exhaustive study, but it's just trying to show if these growth rates continue in a vacuum, basically, this is what you would see. But we know that's not going to be the case.
Okay, in the interest of time, Sean, let's go with two more here.
Okay.
There's a few to select from, but please confirm your eligible cost for Ontario and if the final number is per eligible insured member or actual certificate. If the individual is insured, what is the per certificate amount for Ontario? It's a bit of a mouthful, but...
So there's two metrics you've seen throughout here. Insured is when we look at essentially everybody in a given month, every individual that's covered under our plans and eligible to claim. They may not claim. And then we just take the total cost over that month and we divide one into the other. When we look at a certificate basis, we have a lot fewer certificates each month because the certificate is just basically the card holder, the employee number. It's the card. It may include other people under it that claim, but so those are the distinction between the two. Not sure if that answered it, but.
Last question, Sean. And it kind of ties to an earlier one here. I think it's a COVID theme almost. How do you, I think what they're trying to say is, how do you see the crossover impact of less dental and or paramedical claims on drug budgets going forward? I don't know if that's in your realm there, but take a stab at it if you want.
Well, yeah, I mean, I have a point of view, like most things. Well, I don't know. It's similar when you think about it. When OHIP Plus came in, it was a bit of a windfall for plan sponsors. There was savings to the plan when that got shifted to the government, and some plans decided to reinvest that. Similarly, obviously medical and dental has dropped way off. Our carrier partners have all gone really and reduced those premiums, so the break's coming there. But that is those plans are going to be under budget than what they anticipated at the beginning of the year. So I really don't know. I mean, maybe they enhance benefits the next year. I don't know. Maybe they try to make up with it with increasing spending account dollars if they have one, or maybe they just take that because they're hurting in other parts of the business, right? So I don't know.
Okay. In view of time, Sean, I think we'll close it off there. Okay. Just want to say thank you, Sean. Great job. And to the audience, we hope you found this time together and the information shared valuable. As always, it was certainly an honor for us to be able to deliver this content to you again this year. As I indicated at the onset, a recording of this webinar will be available in the days to follow. And should you wish to be notified, please visit our Health Benefits Hub on our website and subscribe to the mailing list. Also, as I indicated at the onset, I'd like to ask if you wouldn't mind to please fill out a 3-minute survey you'll receive shortly. We're always looking for ways to improve, and your experience matters to us. And as I mentioned, similarly, we will be submitting this for continuing ed credits. Please expect to hear back from us in a couple of weeks' time. At this point, I'd like to say thank you again to our sponsors and insurer partners for helping make this possible. And a reminder to you, the audience, to join us for our webinar next week, where I will be presenting the latest trends in medication management, but I'm taking a little bit more of a case study approach on the area of diabetes. So I do hope you can make time in your schedules to attend. And also make sure to check out other upcoming webinars on the registration page. Laura alluded to them in her comments at the onset. We have a great calendar of topics to share with you. And now finally, on behalf of everyone here at TELUS, and I want to say thank you for your attendance and participation. And please stay well.